Okay, so we'll start for few questions for allergy and immunology because it's important. For step 3, they say review allergy and immunology. That's important for a few questions, and then we'll jump to cardio and okay. So when we do the PCV 13, what is the mechanism behind the 23 PPSV and 13 PCV 13? What is the mechanism, like the immunological wise? This is the
What?
foundation of independent. Hmm?
So one is conjugate, right? One is with conjugate, one is without conjugate. The PSV, I don't remember which one is conjugate now. I think PSV 13 is the conjugate one, where you conjugate to induce the T cell immunity, right?
Yeah, right. Yeah, exactly. Yeah, so it's
Yeah.
a good job. Yeah.
And then
So, mhm.
the PSV. Am I the one only answering, or is it for both of us? I don't know. I don't want to be too forward.
No. You can go ahead. Yeah, you can go answer. Yeah, go ahead. Yeah.
Okay. And then the other one is without a conjugate, and mostly it's going to induce a humoral um, immunity. Is that what you're looking for? I don't know.
Okay. Yeah, exactly. So there are two types. There one the polysaccharide, and there is the conjugate. Conjugate is stronger, obviously. So the polysaccharide stimulate the B cell. So the polysaccharide attaches to the B cell, and the B cell will formulate antibodies, and in moderate amount of antibodies. Okay, so that's the advantage is decreased incidence of replacement strain due to lack of mucosal immunity. That's it. While the conjugate vaccine, as you said, like the polysaccharide goes to the B cell and the B cell takes it to the T cell. Okay, and the
Sure.
protein component allow activation of T cell receptor, so an increased level of high affinity antibodies with memory cell formation. So this we need memory cell formation for people who are in dangerous situation. For example, elderly more than 65, patient HIV, cochlear self implant, sickle cell anemia, acyplenia, chronic kidney disease. Then we need the PCV, the 23. Okay, after the PPSV and then PCV 23, we supplement that. But if you just have a chronic lung disease, heart failure, and that's it, you just give them PPSV 23. So that's they love these things. They always ask about it. I got this question on step 1, step 2, and I think in step 3 will be a question like this too. So they may ask about the mechanism behind it. Okay, so patient, this one simple question. After transfusion, developed anaphylaxis, which is asthma, eczema, and blood pressure decrease, generalized hives. So what's causing that? What immune deficiency?
IgA
Yeah,
deficiency.
IgA, yeah, exactly, IgA deficiency. So how do you manage that?
Oh, you have to give them IgA deficient during the, if they have if they have to go through transfusion, you have to give them blood that doesn't have IgA antibodies.
Okay, yeah, exactly. Washed are the best. So this is the most common primary immune deficiency is IgA deficiency. So you can expect a question about that. So the how does that present? Mostly asymptomatic. If it present, can present to sinopulmonary and GI infections, recurrent infection, and associated with other autoimmune diseases, for example, celiac and atopy, asthma and eczema. Okay, and anaphylaxis during transfusion. When you order labs, you will find low IgA and normal, everything else normal. So how do you manage it? Supportive therapy plus medical alert bracelet for transfusion reaction for severe deficiency. Okay?
All right.
Okay, so that's okay. Someone is going to Egypt. What vaccine do you give him? Yeah, excellent. Yeah, thank you for answering. Yeah, it's hepatitis A. And what else?
You do yellow fever too, right?
Yeah.
Yeah, exactly. Yeah, you give them yellow fever and so. How about meningococcal vaccine? When do you give them?
For adults,
Yeah, someone who's going to like
college,
like crowded
college,
yeah,
army,
college,
military.
Asian countries, sub-Saharan Africa, and the vaccine is legally required for people who go to Hajj in Makkah, Saudi Arabia, and stuff like that. You see, those are important ones. Yeah, that's about it. You know when we give pneumococcal, and you know when we give rabies. Okay, so this is in a special situation like pneumococcal and rabies. But generally, for someone who's traveling, you give them yellow fever, meningococcal, and hepatitis A. So that's about it. So if you're doing a study and some of the people lost to follow up, what type of bias is that? May happen.
Let's say that again.
So if you're doing a study, okay, and as you follow them up, some of them they did not continue the study. What do we call this bias?
I can't think of a name. If it's multiple choice, maybe.
Yeah, it's a selection bias. Yeah. How about if the study population differ from the target population due to non-random selection method? What do we call this bias?
Wait, one more time.
Okay, so this is what I'm gonna discuss. I'm gonna discuss the selection bias. Is very important and confusing. Okay, selection bias. There are different types of selection bias. Okay, so I'm gonna tell you different scenarios and tell me what type of selection bias is this.
Okay.
So if the study population differs from the target population because there's non-random selection method. For example, I take people from the hospital, I study them for MI. I take people outside from the hospital. What do we call this bias?
Is the Bayesian bias?
It's a sampling bias, ascertainment bias, okay? Does it?
Sampling?
Yeah. And then the second type of bias, when there is high non-response rate to survey questionnaire, can cause error. Okay, if the non-responder differ from the responder, what do we call this bias?
I know is the non-response bias is also like example of a selection bias.
Excellent, yes, non-response bias, sample selection. Okay, if the disease is studied using only hospital-based patient, may lead to result not applicable to target population. That's a Percussion bias. Okay, so you're right. So you answer. So when you have exposure that happen long before the disease assessment, can cause the study to miss the diseased patient that die early or recover. What do we call this bias?
Let time.
It's called prevalence bias, Niemann bias.
Which one?
It's called Niemann bias, prevalence bias.
Can you repeat the definition again of prevalence?
When the exposures that happen long before the disease assessment can cause the study to miss diseased patient that die early or recover.
So basically the exposure has happened before they started the study.
Yeah. Exactly. Yeah. So it's called Niemann prevalence. Never seen a question about it, so it looks like it's a low yield, but just keep it in the back of your head just in case. And one last one is there's significant loss of study participant may cause bias if they lost to follow up and differ from the remaining subject. If people who lost to follow up differ from the remaining subject, what do we call this bias? What type of selection bias is that?
Is it attrition bias?
Excellent. Yeah, it's attrition bias. Okay. So you know recall bias and observer bias. Those are observational. There's another bias. Then when the subject over or under reports exposure history. What do we call that?
Recall.
No, this is reporting bias. Recall if the subject, common in retrospective studies, when the subject negative outcome are more likely to report certain exposure than the control subject. Okay, that's the thing. And the observer bias is that when the observer misclassified data due to individual difference in interpretation of the preconceived expectation regarding the study, they always love to bring this example of renal biopsy in African American pathologists more likely to report the focal glomerulonephritis that's more common, focal segmental glomerulonephritis more common in African American. So that's more, so this is like one type of observer bias, I believe. Okay. Okay, if the test improves survival, what do we call this bias? Like you think when you order the test that detected way before the disease happened, for example, prostate cancer. Okay, new screening test, you just detected 7 years before, you detected 2 years earlier before
Like
the symptom happened. Huh?
lead time
Excellent,
bias.
yeah, it's a lead time bias. And make sure you differentiate that from length time bias. Length time bias detects slowly progressive diseases. And the rapid diseases die people, like for example gastric cancer, like some of them mild, some of them harsh. So that can happen length time. So it's different, the length time and lead time bias, okay? Okay, so another example, if the if the test of a result 200, like for cholesterol, okay, one time showed 200, one time 190, one time 184. What is that? Is that reliable, valid? What do you think?
Oh, okay.
Not reliable, not valid. What do you think? Give me like a...
One is not reliable.
Excellent. Yeah, it's not reliable. So what is the latency period?
You're asking for the definition?
Yeah. What do you see that? What is that?
When
Yeah, go ahead.
dormant, when the disease is dormant.
Yeah, and this is like when sometimes when they give a placebo and they give a statin, when they follow them in 3 years, there's no significant in LDL. Okay, but when you follow them in 5 years, the people with the statin, they have decrease in LDL, but the placebo not. So that's what we call latency period. There's a couple of questions about that, so just keep it in mind. Okay, like just simple question. If the test has if the 35-year-old female had a negative FNA, and she asks you, what are the chances that I really do not have breast cancer? What is she asking about?
NPV.
Yeah. How about the positive predictive value? How would the question be different if she asked about?
Yeah, negative predictive value, right?
Yeah. But if the positive predictive value, how can I change the question to be the positive predictive value, the right answer?
So if the test is positive, and then she asks how true, whatever, how do I put it?
Yeah. How likely I'm positive? How likely I'm positive?
Yes, how likely that this test is truly positive or something like that.
Yeah. No. Something is very, like, it's always, like, it's crazy concepts that
you say the probability, I don't know.
Yeah, it's always, yeah, it's annoying. Like, when you have null, okay, so when you have the confidence interval, if the null value outside the confidence interval, okay, so what's the 99% confidence interval and what is the 95 confidence interval? Like, just keep it in mind, just in case they ask you about it. What do you think?
So 99% means 3 STD, right? Interval. 95 is 2 SD interval. 68 is 1 SD.
Yeah, you're right. Yeah, something I want you to keep in mind, the p-value, you remember the p-value, if it's less than 0.05, that's less than 95% confidence interval. But if it is less than 0.01, that's 99% confidence interval, okay? Just keep it in mind, just in case they ask about it, okay? You got the idea?
So you're asking it in reference to the confidence interval.
Yeah, p-value and relative to the confidence interval, yeah. If it's less than 0.01, that means 99% confidence interval. Okay, so this is more confident, okay? Because, you know, it makes sense. You see, when less than 0.05, the probability, like p-value, what does it mean, p-value? I mean the probability of being the study is wrong, okay? That's what the p-value means. So when it's 0.05, how much is left from 0.05? 95, right? If you add 95 plus 5, that's 100, okay? So that's very important. Do not confuse these things. So if it's less than 0.05, that means there is a chance of our study being wrong, it's 0.05. And the chance of our study being right is 0.95. That's what a p-value means. But when I tell you p-value is 0.01, that means the chance of our study being wrong is 0.01. But the chance of our study being right is 0.99. Okay, so which one is better? Like, which one is stronger study? If you have p-value 0.01 or 0.05?
0.01.
Yeah, excellent. The lower the number, the better.
Okay. I have a question for you, Dr. Ali.
Yeah, go ahead.
The confidence interval, are you going to get there later? You know, because I have a question about those, you know, the null value containing 1 and not having 1 and, you know, all those things. Sometimes it's very confusing, you know, when they ask you that the confidence interval contains like a null value. How do you interpret that, or, you know, those ranges?
Yeah, we can definitely do a discussion about that. So this is what I separated the biostat that I think it's a hard one. I separate them in a separate folder, and we can do them. There are some of biostat questions that I added with the cardio in the same folder, so that's why I gave you some of them. But now we'll jump to cardio. Yeah, but we'll review those things for sure.
Sure.
Okay.
All right.
Yeah. Now let's go down on cardio. So okay. So if you are a 34-year-old Brazilian male who have palpitation and megacolon, what is that?
Palpitation, megacolon. Chagas disease.
Excellent. Yeah, protozoal disease, Chagas disease. Okay, so if you are a 63-year-old woman, when I check your jugular vein, I find distension. I check your blood pressure, I found 90/50. I do chest x-ray, I find widening of mediastinum. What's causing this issue?
How old is the person?
63.
Aortic dissection?
Yeah, aortic dissection can cause pericardial tamponade and cause that issue. So this is like, it's called Beck, you know, but it's Beck's triad. Like, this is cardiac tamponade.
Oh, you're talking about cardiac tamponade.
Yeah, it's a complication of aortic dissection. So you're close. Yeah, you're right. So because, you know, the extension can extend to the tamponade, because how does that present? Like, where are the triad?
Hypertension.
Yeah.
Distant heart sound and increased JVP.
Excellent. Yeah, excellent. Yeah. Okay. So there's a drug that they asked about. They asked about the mechanism of action. Like, there's a drug that causes, like, there's a antihypertensive medication that enhances natriuresis and decreases serum angiotensin II concentration and decreases aldosterone concentration. So what's the mechanism of that drug? So this is just they want to test your understanding for the pathophysiology of RAS, because this is very important.
You've already said it now. You've already listed all the things that the drug will do.
Yeah, but what is the mechanism? What is that? So this I'll give it to you. It's like a kind of like
Is this
weird question.
aliskiren we're talking about?
Excellent. Yeah, aliskiren. It's a renin inhibitor, direct renin inhibitor.
Okay.
Okay, that's the only one that causes decrease in angiotensin too, and decrease in aldosterone at the same time, enhanced materialism. What's it? Okay, simple question. If you are a 62-year-old male with a pulsatile non-tender mass above the umbilicus, what should I do here?
Can you repeat that again, please?
If you have a pulsatile non-tender abdominal mass above the umbilicus,
Uh-huh.
what does that mean?
Aortic aneurysm.
Excellent.
Abdominal aortic.
Yeah, abdominal aortic aneurysm. So we do abdominal ultrasound. We do monitoring for that. That's the gold standard for. Okay, so if you are a 70-year-old man, okay, who have a near syncope on exertion. Okay, so what do you think is causing this issue? When I do EKG, I found left ventricular hypertrophy and secondary ST segment and T-wave changes. What do you think is causing this?
Are you talking about aortic stenosis?
Excellent.
Or left ventricle?
Excellent. Yeah, that's a good. And that's how I'm gonna give you a trick.
To answer the questions, I don't know.
Huh?
Do you want us to take turns to answer the question?
Okay, you guys can do that. Yeah. Are you guys okay with that? Okay. Okay. That's
Are you okay with that?
It doesn't matter to me.
Oh, okay.
Because sometimes I have to mute out because there's a lot of noise in my background, so it doesn't really matter.
Okay.
Okay. So,
all right.
Okay. So yeah, you can. It's okay. You guys, anyone can answer. Doesn't matter. Okay. So this is. I'm gonna give you a trick. Very important trick. Let me share my screen. Do you guys see my screen now?
Not yet. At least I. No. Okay.
You guys see my screen?
Mm-hmm.
Okay, I'm gonna give you one clue. I want you to tell me the
I
diagnosis.
can.
Okay.
Because.
Huh? Do you guys see my screen?
Yes, but I'm not.
I'm using.
Yes.
How about you, Dr. Agamanda?
Yeah, I can see because I'm using my. I went out. I just came back.
Okay, yeah. So now this patient, okay, a blood pressure. This one patient, this is blood pressure, and this blood pressure of the second patient. What's the diagnosis of each? By just looking at the blood pressure, nothing else.
The diagnosis of each.
Yeah.
Oh, the bottom one is probably hypertensive. And the top one, I don't know.
How about you, Dr. Agamanda? What do you think?
I can see it. I'm using my phone.
Oh, okay, yeah. So when you have a blood pressure,
yeah,
I'm gonna give it to you. Okay, so if the blood pressure is 110/85, narrow blood, narrow, they call it narrow pulse pressure. What do we call that?
Yeah, narrow pulse pressure. You see, like in aortic stenosis and things like that.
Excellent. Yeah, this is aortic stenosis. How about if you have wide pulse pressure?
Aortic regurgitation.
Excellent. Yeah. So there are questions. It's very tricky. They don't give you anything. There was a question, 2 lines only. They only think the blood pressure. Okay. Rigors. This is wide pulse pressure, so I have to be. Yeah. So just be careful about that. Okay. So if you are a 46-year-old man with weakness and chest tightness, on and off for the past 24 hours, what's best next step that you want to do?
How old? Sorry.
46.
With weakness and chest tightness, you said? Nothing else?
Yeah, that's it. Yeah, EKG shows rapid ventricular rate, like it's very fast rate.
Okay.
Yeah, like
Is the
heart rate,
patient stable or not stable?
tachycardic. It's very tachycardic. Huh? It's stable. Yeah. Yeah. So this is most
It's
likely
stable.
could be it could be hyperthyroidism that can cause atrial fibrillation. Okay. So this is I wanna open the discussion of causes of atrial fibrillation.
Wait, before you go into that, what was the clue in the question that would tell us that it's AFib?
So in the EKG shows tachycardic. Okay, tachycardia. So they have atrial fibrillation, and they're asking what causing atrial fibrillation. Okay.
No, I asked what was the clue in the little scenario that you gave us. That would make us think it's AFib because chest tightness so broad.
Yeah, and the EKG shows like shows no P wave.
So irregularly irregular.
Exactly. Yeah, that's EKG. That's how you diagnose it. EKG is very very important tool. Like when you have even ST elevation, that's an MI taken from the cath like immediately. So it's very reliable. Something reliable test. Okay, so now this will bring us to the causes of atrial fibrillation. So what are the cardiac causes of atrial fibrillation?
The cardiac
Yeah, go ahead. Yeah.
causes of AFib.
Yeah. So hypertensive heart disease, that's the most common cause. If you have coronary artery disease, mitral stenosis, mitral regurg,
Oh, okay.
congestive heart failure, hypertrophic cardiomyopathy, congenital heart disease, atrial septal defect, post-cardiac surgery. Okay, so they are very sneaky. They tell you that aortic dissection doesn't cause atrial fibrillation. One of the options was atrial dissection. No, but if they tell you mitral stenosis, no, that causes atrial fibrillation. Mitral regurg causes that too. So what are the pulmonary causes of atrial fibrillation?
Will it be pulmonary causes? That's a little bit.
So COPD,
Mm-hmm.
pneumonia,
Mm-hmm.
PE, and obstructive sleep apnea. All of these cause atrial fibrillation.
Okay.
How about the other causes of atrial fibrillation? Obesity. Can you imagine? Obesity causes atrial fibrillation. Endocrine hyperthyroidism, diabetes can cause atrial fibrillation. So sometimes they can throw you off. Like they tell you, they give you AKG, like rapid rate, and they give you what should you test next, and they give you weird tests, and one of them HbA1c, and you don't know what's going on here, and so the answer would be HbA1c because diabetes can cause atrial fibrillation. So that's if they wanna mess up with the students like this, like they can ask it this way. Alcohol abuse can cause that, and drugs, cocaine, amphetamine, thiophanate cause that too. Okay. Now, very important question. If you are a 34-year-old man who had hypertension about 220 over 120, okay? So how do you manage that?
Oh, okay, 220 over 120.
Yeah.
So any end organ damage?
No.
I want to see if this is emergency or urgency.
It's emergency. So what's
okay?
first
So
one?
emergency hypertension. So of course you want to, if it's emergency hypertension, you want to use all those blood pressure medications like either nitroprusside or hydralazine or something.
Excellent, yeah. So you gave him furosemide and nitroprusside. Okay. So the next morning.
Why are you gonna give him furosemide?
Just to lower because he had pulmonary crackles, like his pulmonary shortness.
Oh, okay. You said it was CHF. Okay.
Yeah, so after you gave him nitroprusside, the next morning he developed confusion, agitation, tonic-clonic seizure. Why?
Because of the toxicity from nitroprusside.
What do we call
cyanide
that?
poisoning?
Cyanide. Yeah, cyanide poisoning. Yeah. Okay, so if you are a 72-year-old man, okay, and your friend had the abdominal aortic aneurysm repair, and you're asking about your chance of abdominal aortic aneurysm repair. So what is best next step? You do nothing or you do abdominal ultrasound?
It depends on his risk factors.
No, regardless, yeah, if they are smoker, yeah, so this is the USPSTF recommends screening male, active or former smoker, anyone age 65 to 75 with one-time abdominal ultrasound. Okay, so that's an important one. So if his age was 63, then you do nothing. But because he's 72, then you do ultrasound. So that's the guidelines, screening guidelines. Okay?
Mm-hmm.
Okay, so if you are a 65-year-old female who had increasing shortness of breath, weight gain, and lower extremity edema. Okay, so it's a CHF, ejection fraction 30%, okay? So we treated you for CHF, like the medications. I gave you intravenous furosemide, and you're taking bisoprolol, lisinopril, atorvastatin. You're taking all of that. But on the 3rd day of hospitalization, you developed 6 beats of wide complex ventricular tachycardia. What should I order now?
6 beats.
Yeah.
Ventricular.
Yeah, wide complex ventricular tachycardia.
How old did you say the patient is?
65.
So that's what the EKGs are showing.
Yeah. So this is a nice question, in the way that, so when you have patients who have heart failure on digoxin, furosemide, metoprolol, lisinopril, came present with CHF exacerbation, the first thing you do, you give him IV furosemide, okay? So this is very common, can happen. Furosemide worsen digoxin toxicity and can precipitate hypokalemia. Okay?
Oh, okay.
So causes this white complex. So the first thing you do, measure serum electrolyte. And correct electrolyte, and he will be fine, okay? He or she will be fine.
So what was the EKG reading again? You said it's ventricular what?
Wide complex ventricular tachycardia.
Okay, wide complex.
So you said it's a complication of digoxin?
Yeah, so when you have digoxin with furosemide, this will cause digoxin toxicity.
So how did you say we manage it then?
You measure serum electrolyte because that's the thing. Like hypokalemia, because furosemide, how does it cause digoxin toxicity? Because of the hypokalemia. So furosemide causes hypokalemia, worsen digoxin toxicity. So the first thing you do, you measure serum electrolyte, you find the hypokalemia, give him potassium, you stop the toxicity, okay?
All right.
Okay, and so you order serum electrolyte and serum digoxin too, by the way, at the same time, okay? So if you are a 32-year-old woman who had shortness of breath and you just had a recent cold 2 weeks ago, when I examined you, I found bilateral basilar crackles, elevated JVD, and 2+ bilateral pitting edema extending above the ankles.
Mm-hmm.
So what's going on here?
Viral myocarditis.
Yeah, so what type of cardiomyopathy is that?
Oh, dilated.
Yeah, excellent. That is cardiomyopathy with diffuse hypokinesia. Okay.
Mm-hmm.
So what is the highest risk of aneurysm expansion in any patient?
Highest risk.
Hmm?
Are you talking about rupture, or are you talking about hypertension?
Expansion, yeah. Most likely the smoking, okay? That's the most important risk factor causing aneurysm and causing expansion of it too. Okay.
Okay. Oh, okay, you're talking about abdominal aneurysm, not like
yeah,
the
abdominal
one in
aneurysm.
the brain. Yeah, the one in the brain will be hypertension, though, right?
Yeah, you're right. Yeah.
Okay.
Sorry.
So abdominal.
Yeah.
Okay. Yeah,
Other
smoking.
risk factors to keep in mind: age more than 60, family history of AAA, white race, and atherosclerosis.
Okay.
I'm glad I don't have any of them. Okay, so this is a non-STEMI case. Like the way they describe a 60-year-old guy have chest pain for the past 3 hours, and you did cath. You found near total occlusion of the left circumflex artery. You treated with stenting. Okay, so what is the management for non-STEMI MI?
And STEMI.
Mm-hmm.
So
I'll give you some of them, and you tell me the missing part. So you gave him aspirin, beta blocker, statin, and angiotensin converting enzyme inhibitor. What is he missing?
So monooxygen nitrate, Monabash. I'm trying to use the mnemonic. Monabash, morphine, oxygen, nitrate. So we said aspirin, beta blocker.
Yeah, what else?
I think you do also ACE, right? Bash. What is S again?
Statin.
Yes.
He's already on statin.
Okay.
And so you give him the H for
heparin too, Monabash.
Yeah, or you can give him the Dol antiplatelet. You give him aspirin with P2Y12 receptor blocker, which is what medication that causes P2Y12 receptor blocker?
You're talking about clopidogrel?
Yeah, prasugrel, ticagrel. Okay. And plus you give him, and you can give him, when do you give him spironolactone?
For management of NSTEMI?
Yeah.
I don't know about one. The one that I know is you give it when the patient has like a CHF class 3 or 4.
When the ejection fraction less than 40%, you give him spironolactone. Or you can give him eplerenone. Okay. Same mechanism of action. Okay.
All right.
Okay, and you know, so you gotta do Dol antiplatelet for anyone who's in cath, or anyone who done catheterization. You give him Dol antiplatelet to prevent restant thrombosis. Okay. That's the idea of this question. Okay. Yeah, cardio is I think one of the toughest, and they can twist the informations, and one of the toughest questions. So we gotta be careful about it. Yeah. So now this is a question. It's a very important question. So, 43-year-old woman with bronchial asthma, and her blood pressure is 157/93. What labs do you think you should order for her? You ordered urinalysis, you ordered chemistry panel, and you ordered baseline EKG. What is missing? What other labs you should order?
A patient already have established asthma?
Yeah, just having hypertension. So someone presented with essential hypertension. Okay, there are 4 things you should order. Okay, we ordered urinalysis, chemistry panel, and EKG. What else? What is missing?
Or have you ordered the what do you call it? Electrolytes, BMP?
Yeah, that's with the chemistry panel. You ordered thyroid, BMP, CMP. Okay, I ordered all of that. Thyroid, everything I ordered. What is missing? It's called lipid panel.
Oh man.
Yeah.
The way you ask these questions.
Yeah, even like when we do the CCS for step 3 is different. Like so long management, I made couple of good mnemonics for it. Like for example, like a Cataglen, for example. This is a mnemonic. You do it for anyone who starts. Like cut, like CBC, urinalysis, TSH, G for glucose, L lipid, Cataglen. Yeah, EEKG. Okay, so there are mnemonics. So the lipid profile is very important for this patient. Okay, so let's go to the next one. If you are a 76-year-old man who have cough, chest tightness, and whitish sputum production, EKG shows tachycardia, voltage criteria for left ventricular hypertrophy. Transthoracic echo shows moderate size pericardial effusion. Okay, your blood pressure is 142/90 in the left arm and 144/92 in the right arm. What do you think is causing this issue? So this is a very important case. Like when you have an old guy, like a 78, present with syncope while working in the garden, and he had chest tightness and neck pain. Boom, that's a big, very atypical, like it's different. Okay, last week he had a cough, chest pain, tightness, and white sputum production. Now, when you did EKG, shows tightness, tachycardia with voltage criteria for left ventricular hypertrophy, and the echo shows,
Left ventricular
yeah,
hypertrophy.
yeah, and the echo shows pericardial effusion. So what's going on here? Syncope, pericardial effusion.
Syncope, pericardial effusion, or pericardial. Are you talking about cardiac tamponade? Or pericardial? Yeah.
It's an aortic dissection.
Oh, okay, hypotension.
Yeah, so that's the thing. They present hypertension, most common. That's how they present hypertension, the most common.
Hypertension or hypotension?
Hypertension.
So the hypertension, the aortic dissection is contained.
Yeah, exactly. Yeah.
Okay, it's contained. Okay, that's why hypertension.
Yeah.
Okay.
So
Not
the way they present severe sharp tearing, chest or back pain, sometimes neck pain, and more than 20 mmHg variation in systolic blood pressure between arms.
Mm-hmm.
And what are the complications for aortic dissection?
So complications, it can dissect, and it can cause going down. It can cause like a mesenteric ischemia. It can cause like a renal failure, right? It can dissect to the thorax. Yeah, I think those two are the ones that I know. Renal failure, mesenteric ischemia. Let's say about it can also dissect.
Yeah, so it's a good
Those
job.
are the two.
Yeah, good job. So this is a dissection, can compress the superior cervical sympathetic ganglion, present Horner syndrome. It can destroy the aortic valve, cause aortic regurg. It can cause to the carotid, cause stroke. It can cause the coronary, cause acute MI. It can cause to the pericardial cavity, cause pericardial effusion, like this patient. It can cause to the pleural cavity, cause hemothorax.
Hemothorax,
it can cause to the spinal or common iliac artery, cause lower extremity weakness and ischemia. It can cause to the mesenteric artery, causes abdominal pain. Okay, risk factors: hypertension, marfan, and cocaine.
Okay, let's review that again. So if there's a aortic dissection, so you said it can go to dissect to the carotid arteries and can cause like a stroke, right? It can go to, let's say, the heart and then cause like MI, ischemia. Then it can go to the thorax, and cause like hemothorax. Then it can go down to mesenteric arteries and cause mesenteric ischemia with showing abdominal pain, right?
Right.
So where else can it go? So the head, the heart, the lungs, the abdomen, the kidneys. Okay. All right.
Yep. So now, if you are a 56-year-old man who have worsening fatigue and difficulty concentrating, and you became more forgetful, you gained 6 pounds, you have atrial fibrillation, your potassium is 4.4, you're taking amiodarone. So what do you think is causing your issue here?
Hypothyroidism due to amiodarone.
Excellent. Yeah. So now I'm gonna drill you, pimp you with a very tough question. Tell
Hey.
me the cardiac side effects of amiodarone.
Oh, the cardiac of amiodarone. Okay, I know about the lungs. The pulmonary, I know about the pulmonary fibrosis. Okay.
That's what everybody knows about. But actually, I'm telling you from a table, and it's very well organized. This is clearly written. The cardiac causes is sinus bradycardia, heart block, risk of proarrhythmia, QT prolongation, risk of terza di puante. Those are
Yeah,
the
that one. Okay. Yeah,
pulmonary,
those ones.
everybody know chronic interstitial pneumonitis,
Yeah.
cough, fever,
And the
dyspnea.
eye.
Yeah, and they present, chronic pulmonary pneumonitis present with cough, fever, dyspnea, pulmonary infiltrate. So you suspect pneumonia, but in reality, it's not. It's amiodarone. Okay. Endocrine, everybody knows, could cause hypo or hyperthyroidism.
Hypothyroidism.
Okay, both.
And then colony deposits in
What
the
are
eye.
the GI manifestation? Okay.
Man, why do you ask all those ones? Those weird ones.
Hepatitis, yeah. Yeah, that's,
Hepatitis.
I want you to get like the 270 plus. That's what
Amen.
Yeah, amen.
270 plus. Who needs that?
Yeah, you need that,
I'm not gonna be a surgeon. I don't care. I don't need 270.
Yeah. No, it's good to tell your kids and stuff. Yeah, so it's a transaminitis that's they have, and the ocular, ocular, everybody knows about that because corneal microdeposit, optic neuropathy, and what are the skin manifestation?
Oh, the what do you call it? The blue something?
Blue-gray skin discoloration.
Right.
How about neurologic? Peripheral neuropathy.
Peripheral neuropathy. Okay.
Okay, so if you are a 22-year-old female who just went through a breakup and you have recurrent syncopal episode after that, and preceded by lightheadedness, weakness, blurry vision, I examine you, everything is fine. I check your echo since last month, everything was fine. What's going on? What should I do right now? How could I diagnose you?
Okay. Are you talking about maybe like let's say like the person is having like a panic attack, or are you talking about
so panic attack present with chest pain, anxiety, shortness of breath.
are you talking about the what do you call it? The vaso, it's not vasovag, is it vasovagal? No, yeah, vasovagal syncope. Yeah.
So this is so the presentation is different in elderly and in young. So both of them, they have prodromal pallor, dizziness, nausea, diaphoresis, and short duration of syncope, seconds to few minutes, doesn't last long. And symptoms improve with supine position. Okay.
Sure.
So, wow, it's very interesting. Wow, the body how reacts like this. Yeah, it's very. One time I remember one of my friends, like he first year of medical school. It was very tough, like they were so harsh on us. Like they're so like Like you have to know anatomy and stuff, so it's very annoying. This guy, like, he came from different system and stuff, so it was very tough for him. So during the class, he just lost consciousness. He just lost and stuff. So luckily
I'm
there
passed
was,
out.
yeah, he passed out. Luckily there was a neurologist in the giving lecture in the second hall. So he came. He said put the paper on his mouth. So I held the paper. He asked me to put the whole paper on his mouth. So I held the paper on his mouth so that he gets the same CO2. Okay, so that increase
Oh,
level of,
CO2, breathing
yeah, so
CO2
that
back.
increase the level of CO2 and stuff, and he was able like to regain the consciousness and stuff. So it was emotional stress. Yeah, it's very tough. Yeah,
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 I guess
yeah,
on all of us.
yeah. Maybe it was because of the anatomy, or maybe a girl broke his heart or something. I don't know.
Actually.
Yeah. So it is, yeah. So the at the age less than 60, most likely emotional stress, venipuncture, prolonged standing, heat exposure, exertion.
Mm-hmm.
Okay. But when you are
Mm-hmm.
more than 60 years old, you don't care about emotion. Triggered by micturition, cough, and defecation.
Direction.
Can you imagine how terrible it is? You go to urinate and you lose consciousness. Like, what's going on? You know? Yeah, it's very tough. Like 60.
Yep, it can be.
Yeah, it's crazy. Yeah.
Mm. I have a question for you though, not now, maybe later,
Yeah. What is it?
about the step 2 exam.
Yeah, of course, yeah, sure, no problem, yeah. Yeah, so that's about it, yeah. So when you're more than 60, it's triggered by micturition and cough and defecation. Yeah, that's the thing.
Okay.
Yeah, that's the thing. Interesting, I just saw a video, it was very interesting. Like there was a girl, she's 24 years old, she's
Mm-hmm.
Brazilian, and her partner is 65-year-old girl too. So it was like very interesting, and they had video and stuff.
How old is she?
Like she's 24 and her partner is 65.
Oh, like her
Wow.
grandpa, huh?
Yeah, like grandpa, I don't know, because and they're
Oh,
in a relationship and stuff. It's interesting, yeah. Yeah,
oh
so
wow.
yeah, so how do you diagnose vasovagal? It's mainly clinical. Sometimes you do
Mm-hmm.
apparatus testing, but otherwise it's clinical. How do you prevent it?
Oh, you said, what you said, like, prevent. Is it the one that you cross your leg? You learn how to,
Exactly.
yeah, cross your leg or do like a hand grip or something like that.
Yeah, this hand grip, it's important even in the exam. When you're so tired in the fifth block and you're
Mm-hmm.
dying, just grip your hand, okay? Squeeze your muscles. Okay, this is gonna help because this.
Oh, really?
Yeah, because these USMLE exams uh, are against human rights. It's so you gotta be so you gotta be prepared for it. Like because it's crazy. Like they make you sit for 9 hours there and
So when you do hand grip, what does it do
like
in the exam?
give you blood to the brain more helpfully.
Okay.
Take
Okay.
Valsalva also. You do Valsalva helps too. Yeah, because I'm telling you, this
Okay.
is against the human rights. But what are you
I
gonna
know,
do?
9 hours.
Yeah. Yeah. So if you are a 72-year-old man who has sustained brief loss of consciousness,
Mm-hmm.
okay, and when I check your blood pressure is 136/83. Okay, and you have loss of consciousness when standing. So what is your diagnosis?
When standing orthostatic.
Yeah, orthostatic hypotension. Okay. So let's do a rapid review, okay, and then we'll take a break. Let's do a rapid review of whatever we did for today, for this hour, so that we consolidate. Okay, so we discussed about the conjugate vaccine and polysaccharide. Polysaccharide is not as strong as the conjugate. Conjugate is the PCV23. Polysaccharide is PPSV23. PCV13, sorry, is a conjugate, and PPSV23 is a polysaccharide. When you have IgA deficiency, you better have a medical alert bracelet, okay? When you go to Egypt, I'll give you hepatitis A vaccine, okay? And when you lost to follow up, that's called attrition bias, part of selection bias. When you compare hospital with general population, that's Bergson bias, selection bias. Okay, when the subject over-report or under-report, that's a reporting bias, part of observational bias. Does the thing. So if your cholesterol test shows 200, 190, 180, that's an unreliable test. Okay. If you are okay, there's a latency period when you have to use statin for 5 years to show the effect. Okay, so if you have megacolon and palpitation, that's a protozoal disease. It's Chagas disease. So if you have JVD with hypotension and wide mediastinum, that's a tamponade. If you have pulsatile non-tender abdominal mass, that's an aneurysm abdomen. If you have exertional syncope, that's aortic stenosis. If you have atrial fibrillation, then it could be caused by diabetes or hyperthyroidism or many other causes, like pulmonary embolism and OSA. If you take nitroprusside and have confusion, then most likely cyanide poisoning. Okay, USPSTF recommends screening smokers at age 65 to 75 with abdominal aortic aneurysm. Okay, if you have heart failure, I gave you IV furosemide and you develop tachycardia, I'll check your serum electrolyte and serum digoxin. If you have an infection 2 weeks ago, now you have crackles and leg edema, that's most likely dilated cardiomyopathy. Okay, smokers are the strongest risk factor for abdominal aortic aneurysm. If you have non-ischemia, and with catheterization, I'll give you DOL antiplatelet with beta blocker and AC inhibitor and statin and spironolactone ejection fraction less than 40. If you have essential hypertension, I should do urinalysis, chemistry, lipid panel, and EKG. If you are a 78-year-old man with chest tightness and left ventricular hypertrophy, pericardial effusion, and syncope with exertion while walking, and with neck pain, that's most likely aortic dissection. And the dissection can present in different ways: abdominal pain, Horner syndrome, stroke, MI, effusion, hemothorax, lower extremity claudication, whatever, you name it. Okay. If you're taking amiodarone, then we gotta check. You can have eye problem, GI symptoms, hepatitis, hyperthyroidism, heart block. It's a terrible drug. Like, it's horrible. Like, destroys everything. Literally. Like, what is?
I don't even know why people take it.
Yeah. I mean, you got no option if you have heart failure and your heart is playing atrial fibrillation. Tell me, do you have any option? You don't have any option, right? And you're on metoprolol already and didn't control your rhythm, then you gotta add amiodarone. There's not much you can do. Maybe these people already are 7 years old already, like, so, and they are in a terrible situation already, so it's okay, like, it's not. That's gonna prevent them from syncope, so it's helpful sometimes. So if you have vasovagal syncope, then we gotta provide education how to prevent that. Okay, if you lose consciousness when you stand, that's orthostatic hypotension. So make sure you exercise now so that you don't have it when you grow older. That's about it for this hour. Okay, so currently I'm having a session at 4:30. I already scheduled, so 4:30 to 5:30 CST. So maybe after that, maybe around 6, I'll let you guys, and we can continue the second hour. Okay?
Okay.
Do you guys have any other questions or concerns?
What kind of session are you having right now?
4:30.
Yeah.
Is it for CK?
Yeah, it's for the U-word step 3.
Oh.
These types of questions. Okay. Yeah, you guys can join if you want. Yeah, but it's gonna be like this is the first time I'm gonna tutor him. So
That would be interesting. Can we join and just be quiet?
okay, you can. Yeah, I don't mind. Yeah, that's okay.
We'll just be quiet.
Yeah, yeah, okay, that's okay.
You'll start it at 5:30 EST, right?
Right, yeah.
Till what time? 6:30? Or
Yeah, 6:30.
for 1 hour? Okay.
Yeah.
We can leave like anytime, quietly, just leave.
Yeah, that's okay. You can do that.
Yeah, I'll join in at 5:30 then.
Okay, no problem.
Okay.
Okay. You guys have a good
Dr.
day.
Ali, I have a question for you.
Sure, yeah.
Okay, about the exam.
Sure.
These are news from the usmle.org about, the cutoff time. If you take your exam before June 23, then you're going to get your result like in 3 weeks. But if you don't take it, if you take it after June 23, you're going to get your result like almost end of August or September.
Yeah.
Do they normally do that every year?
Yeah, they do that actually. Yeah, they did that. I don't know why they do that. Like they just add stress to people, but they do that. Like almost every time I had to take my exam, they do that. Like they play this game.
What do you advise? Do you, because I was asking some people, they are saying, that because this this one that is going to end June 23, that maybe the curve is going to be too difficult.
Yeah, some of them, they say, I heard that, and they used to freak me out about these things too. But to be honest with you, like, take it when you're ready. Okay, so it's not a big of a deal. Just take it.
I don't want to take it when they will just like do like a difficult curve, and then instead of passing very well, you're just like
Yeah. So you see, so this is, let me tell you, I'm gonna give you something individualized for you. Your medical knowledge is great. Your USL1 is amazing. So this is what I recommend. Do your self-assessment too, like around 10th of June or something, and take it before 23. Yeah, you don't need to postpone that. Yeah.
I don't need to postpone it.
For you, yeah, I would say don't push it. Yeah, you're good to go. I'm telling you.
Really?
Yeah. Just do
okay.
your self-assessment too, and let me know how you do on that, and I'll give you more feedback.
Advice. Okay. All right. No problem. Okay. All right. I will join the step 3 and see what is going on.
Okay.
All right. Thank you, Dr. Ali. Bye-bye.